afternoon, everybody. We're here for another episode of Stewarts Soundbites, and I'll just let people join for the next minute or two. But we haven't got long. We're gonna really struggle to get everything in this session, but we're gonna do our best. Um, Today, Katrina, I don't think I need to formally introduce you because people on this call will know who you are. But for the sake of being thorough and doing things properly. I'm so delighted to be joined by Dr. Catriona McIntosh today. Katrina, as you will all know, is a consultant clinical neuropsychologist, and you now do a lot of expert work. That's right, isn't it, Katrina? You're focusing on your expert work at the moment.
I do, and also quota protection capacity assessments and a
Of
small amount of
course.
treating work as well.
Okay, so busy. Um, so today, this is a such an interesting topic, and it's really quite niche. Well, I started off thinking it was really quite niche, and as we've talked about it, I think, oh, I need to be thinking about this in kind of every aspect of my practice. So maybe it's not so niche, but it's a really super interesting point. And when we first talked about doing or covering kind of gender and age bias in the context of capacity assessments, I was thinking, really, this is, for capacity assessors. And, as we've talked about it a bit more, it's more about how these biases creep into information from a whole pile of different sources, even from well before a referral for a capacity assessment ends up with you. It's looking at that, you know, from all sorts of different sources and different perspectives. Um, I'm being a bit cryptic. You're going to explain this better than me. But we talked about how that manifests in terms of gender and in terms of age specifically. There's a whole lot of other things, but the easiest way I think to deal with this, Katrina, and the way I kind of digested it, from you was hearing from you about some of your experiences in this regard and how that applies in practice. So do you mind telling us, particularly on
Sure.
the gender point, a little bit about what your experience has been of this?
I'd be fascinated to see some actual research on this of for instance, quarter protection capacity assessments. But I think I've noticed patterns over time in certainly the referrals I receive. From a gender point of view, for capacity with sexual relationships, there is a trend of men being assessed for capacity with a theme of concern for them as perpetrating without obtaining valid consent, and women as vulnerable. Can they give consent?
Mm,
And are other people taking advantage? And that really struck me as quite significant. And not that there aren't reasons for that, but I held some concern around sometimes patterns in how professionals, solicitors, people around the person were interpreting and perceiving issues, and whether that was influencing the referrals in the first place, and then sometimes influencing capacity assessors as well, because I think there's a risk sometimes we take the information we get as gospel truth, as fact, because we've been told it. So a recent case of this was a solicitor sent me a referral to assess capacity for sexual relationships. And actually, as she explained it, I was like, why are we considering this at all? Because you're telling me that this woman is sending inappropriate sexual images to multiple people, including a child. And I've had similar cases with men, and the focus is always on the risk of the man. That are they deliberately doing this? Are they perpetrators? And yet this wasn't even considered for this case. And I said, has anyone considered whether this woman is doing this deliberately or not? And they were, oh goodness, we haven't thought about that.
mm,
Do we need to contact MAPA? Do we need to think about why this is happening? And
yeah.
certainly as risk protection measures as well. So I I personally believe, I might be wrong, but I think the angle that would have been taken would have been different if that was a man sending sexual images to a child and other people than the
Mm,
woman. The woman was sort of deemed benign, and the focus was on her capacity for sexual relationships herself. Again, not thinking about internet use or other things. So I think those are some of the differences we can see. Again, I've had women referred because they were having lots of casual sex. And actually, when you ask the woman, she said, well, that's what I want with this person. I like a regular casual situation. We both want it. We don't want to be together. And actually, one of the reasons for concern was because her mother wasn't comfortable with casual sexual relationships and was worried about the risk. And actually, it was her mother's view on what a relationship should be. Because her mother turned around and said, well, if you took her out for dinner, it'd be fine. And I was
Mm.
like, oh. So that had influenced some of the thinking on the case. And that was a complex case with more issues. But it's an example that I don't think, a similar young man would have been referred for, with that aspect of that case,
Mm.
that risk of casual sex. I think a young man that might have been deemed as not unusual, for instance.
Yeah.
And one of the things we were talking yesterday, Emma, is saying I what I try to do now because I started noticing these patterns. And I sometimes suggest it to people is change it around in your head. If this was a person of a different gender, a different culture, a different age, would you think anything differently about this case?
Mm.
Are you treating an 80-year-old differently to how you treat a 20-year-old? Because we make assumptions that maybe the 80-year-old doesn't want sex or shouldn't have sex or. So I think when you change it around and think, would I respond differently if there's a woman or a man? We can sort of sometimes catch some of the influences that might be impacting on the referral information that might have crept into our thinking that we might
Mm.
automatically go into being a bit more protectionistic of someone we deem to be vulnerable or someone we deem to be, a risk to other people. So I think that's a useful thing I found quite helpful to do.
It's quite confronting, really, isn't it,
Mm,
Katrina? Because I think we all like to think of ourselves as kind of fair and level-headed and impartial when it comes to this sort of thing. And sometimes, as you say, it's quite interesting to catch ourselves and and examine our own assumptions. And I was thinking about this in the context of clients that I've worked with previously from different age groups and all sorts. And am I making an assumption based upon mum telling me that, oh, since the accident, this and this has been a problem, and the extent to which you accept that based upon preconceptions and delivery by someone in the family. I think it's a super interesting point, and it becomes more complicated, doesn't it, with um somebody who, and this is your experience presumably with the court of protection work, Katrina, when somebody has been through maybe a transitory period of rehabilitation or been in a care home setting or kind of being in other settings where things are recorded in different ways. It's such a it feels like quite a responsibility, to challenge yourself and how you think about these things and what referrals you make and what discussions you have.
yeah, but it's a normal thing. We all get, but our biases are our shorthand for how do we make sense of the world.
Yes.
It's okay that we use those because that's how we all practice.
Mm.
They're automatic. But I think if we become aware that sometimes our thinking patterns get pulled into directions or might be influenced by the language, the narrative that's grown around a person, we can take a step back and restart again and think, what does the person say? Because quite often, if you think about a capacity assessment, I'm certainly struck that usually it's got the risk concerns of other people noted,
Mhm.
but often not much information or no information on what the person themselves says about it. And it's sort of assumed, well, that's part of the capacity assessor's assessment.
Yes.
But actually, does it have to be? Like,
Yeah, yeah.
why? There might be a really good explanation if we ask that person before we consider, we've got to have reasonable doubt for capacity. Ask them why they're doing things.
Yeah. Again, confronting, isn't it? I mean, it's so
Yeah.
super interesting. And we talked a little bit about, and you've set me off thinking about all sorts of things. And this is as I said to you earlier, this is the beauty of doing this series, and speaking to people like you, is that it actually makes me reflect a lot on my own practice and other people. We've got therapists and case managers and lots of, wider MDTs that will watch this and reflect upon our own practices, which is so useful. But what I thought was super interesting was the connection then between all of this to stripping back again and examining whether somebody's behavior, specifically in the context, I suppose, that you're talking about here, Catriona, with sexual capacity and things like that,
Mm.
and looking at whether someone's behavior is linked to their brain injury because it's been
Mm.
presented in that way. Is that
Yeah.
causal nexus there?
Causal nexus, and sometimes assumptions can be made. I'll give you an example of a gentleman I assessed last year in his 70s.
Mm.
And I was sent a referral of how he had inappropriate sexual behavior. This is part of his DOL Section 21A appeal. So I went along and I said, this, you've got a care plan for inappropriate sexual behavior, but basically the care plan was 24-hour, 15-minute observations to prevent him from having sex with another resident. I couldn't see any documents of inappropriate sexual behavior other than that he might have sex with this other resident. And I said, is it always the same person? And they went, oh, yes. Have you got any idea whether they, one or both of them might want this is consensually? And they went, oh, yes, they do. It's absolutely consensual. And I went, what made you wonder about capacity? Have you assessed capacity? Oh, no, we've not done that. What made you doubt it? And I said, well, they said he's on a dolls.
Okay.
So we've now got a huge assumption that this older man cannot have a sexual relationship because he's on a dolls, which is a bit horrific. He then had a 2 year enforced celibacy as a result of 15-minute observations. Hugely intrusive. There wasn't a need for that at all. Labeled as sexually inappropriate, which I'd be horrified. Imagine how his family feels if they find out about that. And actually, he was having a consensual interaction with someone else, but his dementia meant he didn't understand that they were preventing it. He couldn't raise concerns about it at all. So he was very vulnerable to having his rights not being respected. And this really was about a lack of understanding of the staff, but it all went down as a label of inappropriate behavior due to dementia. And it was
Yeah.
nothing to do with dementia at all, really.
Yeah.
So this is quite the language, the labels on cases, and they become the narrative. They go in the records. The letter from the solicitor in this case, my letter of instruction, referred to, he has sexually inappropriate behaviour and regular checks as a result. And it sort of follows people around. You can imagine if he moved care home, that would then follow him, and nobody would know what the initial reason was. So it's quite powerful stuff, and I think ultimately people write notes and records, and it's their lens of perception, their belief system, and with the best will in the world, things might be influenced by their understanding.
Yeah.
Sometimes it can be useful to step back and reconsider the situation and why something might be happening. And exactly that, as you say, the causal nexus, because it's very easy to list a diagnosis as the reason someone's doing something.
Yeah.
And actually, it might be completely unrelated to it.
Yeah. Yeah. It's terribly sad, actually, isn't it?
Mm.
And it's such a huge problem actually because, as you said, that the dissemination of that information came primarily from the staff in the care home there. And I mean, it just require a huge amount of education to think about capacity in a way that's required. So, does I suppose the issue for that gentleman particularly is his was his sexual activity consensual at the time? Did he have capacity to
Mm.
consent at the time? And then to what extent does the dementia and him being able to remember and impact, all of those kind of complex, more nuanced issues are really hard to
Mm.
get right. So it's a big responsibility, but as you say, it's the usefulness of kind of stepping back and asking questions about the information that you've been provided, and considering referrals, particularly for capacity assessments. But oftentimes, I think there's probably not enough confidence to do that without speaking to someone like you.
I guess we're all get the emphasis of does our client, can they understand and weigh the information?
Yeah,
And I guess there's a risk that we take the information we're given as the information. And I would encourage people to think, right, that's what I've been told. When I go out, let's have a look fresh. What is the relevant information here? What is going on? What's the formulation of why this is happening? What do they say is happening? Is it possible that P's got a better understanding of what they're doing than some of the
yeah,
other people around them? That would be our first port of call for any other situation, wouldn't it? It's why does
yeah,
the person say they're doing what they say? So I think we need to treat things just with a just carefully sometimes. Most of the time, our information is absolutely accurate. I'm not saying this is all cases, but certainly it's often enough that it's been a pattern I've noticed that there might be an aspect of why you've got that referral that think, would you have got it if it was a man? Would you have got it if it was a female? Would it be phrased differently? Does this mean they've looked at all aspects of the case? Because the referrers might be absolutely correct. We need to look at capacity for sexual relationships or this, or the person's vulnerable, but they might be forgetting another angle of it. Certainly, when looking at vulnerable women, quite often I've seen themes of absolutely not engaging with the fact that this person maybe has severe memory confabulation and is has a regular pattern of making inaccurate allegations against staff, residents, and so on, which means there's a huge risk in a sexual relationship that they could make false allegations. And that is something I do see at times, occasionally, with people with memory confabulations and brain injury. And how do we support that risk?
Mm.
So that we're considering the risk to the partner as well as to the client. And actually, that when we focus only on the woman who's deemed to be vulnerable, we might miss the wider issues that we need to think about. So it's sort of moving away from that binary idea of referrals because someone's vulnerable or a perpetrator, but actually thinking, has this person got capacity for the decisions they're making, but also what are their support needs around this area in their life so that they and others' well-being is supported. Because I think sometimes the information, if it's a bit narrow and focused, might pull us into a particular direction that can
Yeah.
influence our assessments and recommendations.
Yeah. And I think there's a temptation, as speaking from experience of running cases, there's a temptation to think I'm going to get my capacities, I'm going to get my neuropsychologist on board, and we're going to get to the bottom of all of these issues. But actually, wider than that, the treating team, the case manager, the
Yeah.
capacity assessor, the solicitor, all of us, need to reflect upon our own practice and step back from things sometimes. And that the point that you raise about how we deal with and kind of consider risks to others surrounding an individual that's maybe undergoing the capacity assessment is super interesting, and thinking about a care plan or whatever it might be to
Mm.
protect another person, because it opens the door, doesn't it, to all of these knock-on effects.
Mm.
Basically, it's quite it's a lot to take in and think about, actually, in the broader sense, but it's really important. And one of the things that you touched upon about the family's perception of risky behavior
Yeah.
is super interesting, and how we digest that and how that's recorded.
And families might be coming from worries that they may understandably hold rather than thinking, what is that person wanting and what decisions have they got capacity for? So
Yeah,
sometimes they might be at odds, and yet families might play a huge role in driving those concerns around capacity and risk and
yeah,
whether that referral goes forward. So I guess it's how do we support vulnerable clients to have that voice and to ensure that we do those assessments and support
yeah.
their rights as well to have fulfilling sexual lives and to be seen as sexual beings. Consistently, people who are disabled say, often especially people in wheelchairs say other people don't view them as sexual beings. They
Mm,
don't get referrals for cervical checks, smear tests, and so on because people assume they're not sexually active. So
mm,
that people can be really vulnerable to assumptions being made about their lives. And yeah, it's just something to be just to check in of would we do it
yeah,
differently, rethink it. Is there a narrative that's maybe influencing this letter of instruction? Um,
yeah. Have
and
you
it's
seen
okay
that?
to challenge those things and gently suggest an alternative as well.
Yeah. Have you seen that with age as well? Sorry, I know we're running over, but I promise I'm going to ask you questions. We'll talk about it all day. But in terms of the age issue as well as with gender, we've touched on gender quite a lot. I'm just conscious that it's an issue with age, isn't it? You've already given an example involving an elderly
Yeah, and
gentleman.
sometimes of family members finding that really distressing
Yeah,
that their elderly mother or father is wanting to have a sexual life. And a problem with, court of protection cases, that's all exposed. There's
yeah,
not a lot of privacy in that. And having discussions around that can be really hard. And they might think, well, they should be. I've had family members say, well, they shouldn't be doing that. They should be past that. Well, if that person wants to do that, and they've got capacity, that's their choice.
Yeah.
So it can be understandably very difficult for people in that situation. But our role is supporting that client and trying to help say, well, this person's got that same right as anybody else. You know, age is not a factor for this. We can't be bringing age into this.
Yeah. And you see Pat, I mean I've seen it as well, patterns in younger men with brain injuries who, you know, there might be assumptions around their lifestyle choices
Mm.
and worrying behavior in a financial context as well, I suppose. Um, which is something really to reflect on too.
Uh,
Um,
I think class and personal values can come onto that again. I had
yeah.
a striking client who, the solicitor was very concerned about their financial actions. He'd already been deemed to lack capacity for his financial affairs, and I was reassessing it. So one of the pieces of evidence I was given of the concerns is that he kept using PayPal loans and getting into debt, having PayPal debt with these. Um, and when I asked him, I said, well, why are you doing this? Because the solicitor says you've got all this money from your settlement. You should just be using that when you're needing extra top-ups or presents and so on. And he said, well, why would I do that? When I contact my deputy, every time there's a fee. Have you seen how much she charges? He knew what she charged per 15 minutes. And he's like, well, I have to have a discussion about why I want that money. And that I don't want to do that. If I need a bit of extra money, why should I have to explain it that I want to give someone a present? I want to do it. And she'll bill me. Whereas a PayPal one, it's interest free. So it doesn't, I pay it back every single time. So it doesn't, I don't pay any extra for it. So it's much cheaper than going to my deputy. And I'm like, fair dues. It's protecting his identity, of not asking with a begging bowl for money. It's meaning that he saves money, which I was really impressed with. And he also explained that for him, it improved his credit rating. And for him, credit rating was really important. All his life, he was a cash man and he needed a good credit rating, which going to a deputy didn't do. And it made me stop and think because I'm not someone who likes getting into debt. That's my upbringing. Other than your mortgage, you wouldn't, even interest free, you try and avoid it at all costs. And I possibly, like that deputy, would have gone, why are they doing that? They've got all this money. Why are they doing that? And I'd probably be
Yeah.
the person, I'd be the fool who would phone up the deputy saying, can I have some of my own money, even though it was costing me? But he had a really impressive attitude to that. He had considered it, he had weighed it, and he had an explanation that none of us had considered. But what hadn't happened so far was anyone else asking him why he was doing it.
Mm,
It was being cited as poor financial decision making.
yeah.
So that asking people is really, really important. And also
Mm,
accepting that sometimes our own lifestyle beliefs, experiences might influence our lens of how we see things
yeah.
and kind of listening to the client who might have a different perspective.
Yeah. Super interesting. We could do much more on this. And we haven't preparing for this episode talked for longer. So we've actually done well to curb it. But I think there've been some really good kind of practice points and just points of reflection, which is what the series is all about for us. So thank you ever so much. Katrina, I'm so grateful to you. It's such an interesting, seemingly quite niche topic, but actually has big kind of knock-on effects in our practice, doesn't it?
Well,
So
thank you for having me, Emma. Lovely to join you again.
yeah, it's a pleasure. Thank you so much. Thank you, everybody, for joining. We'll see you next month for unbelievably the very last episode of 2025. I can't even believe that we're here, but here we are. And we'll look forward to seeing you all again soon. Thank you.
Thanks. Bye.
Bye.